السلام عليكم ورحمة الله وبركاته. معكم راد الغامدي ميديكال انتر. أرحب بكم مرة أخرى في لقائنا الثالث لهذا الأسبوع بعنوان Cardiovascular Emergencies مع الدكتور عبد الرحمن الشريف، طبيب مقيم في تخصص طب الطوارئ في مدينة الملك عبد العزيز الطبية الحرس الوطني بجدة. أحب أذكركم بكتابة أسئلتكم في المكان المخصص للأسئلة، والدكتور إن شاء الله حيجاوب عليها نهاية اللقاء. حيكون في شوية سيناريوز وكيسز، فأتمنى تشاركوا مع الدكتور في الشات. نبدأ على بركة الله. اللهم يا معلم موسى علمنا، ويا مفهم سليمان فهمنا، ويا مؤتي لقمان الحكمة وفصل الخطاب آتنا الحكمة وفصل الخطاب. دكتور عبد الرحمن تقدر تتفضل.
السلام عليكم ورحمة الله وبركاته. يعطيكم العافية جميعا. أشكر لكم استضافتنا اليوم. نشكر الأخوان القائمين على لجنة ساسم. من لا يشكر الناس لا يشكر الله. يعطيكم العافية جميعا. طيب، معكم عبد الرحمن الشريف, Senior Emergency Resident, National Guard Hospital. So today we're going to talk about inshallah cardiovascular diseases في emergency. طبعا actually this is kind of big topic, and we at least we last for 5 weeks عبال ما نغلق هذه كل المواضيع اللي نحن ناخذها في cardiovascular diseases. So our objectives today is gonna be, we're gonna talk on BLS and ACLS, approach to arrhythmia and acute coronary syndrome, hypertensive emergency and cardiac tamponade. طبعا الشات حيكون مفتوح, في بعض الأسئلة حأسألها وحيكون يعني شوية في discussion على أساس تعمل الفائدة الجميع إن شاء الله بإذن الله. طيب, let's start with the BLS things. The basic cardiopulmonary resuscitation. Our objectives today in that topic is gonna be, we're gonna talk about basic CPR and approach to unresponsive patient, basic maneuver for opening the airway, and how to deal with obstructed airway. All of these things outside of the emergency room, okay? So in the beginning, there is a specific sequence of steps for basic CPR. I think most of you, they have a BLS certificate and they are a BLS care provider. So do we start first with the ABC, airway, breathing, then chest compression, or we start with CAB, which is chest compression and airway and breathing? So what, yeah, great, excellent. So we start with the CAB, not the ABC. In cardiac arrest, or if the patient is unresponsive and there is no pulse, we start with the chest compression, then we open the airway and we deliver rescue breathing. The AHA, in the past, they used to say, first we open the airway and then deliver breathing, then the chest compression. But actually this has been for a long time, it's been replaced with the CAB. Compression rate, does anybody knows how many compression rate per minute? 30 to 2. This is regarding the kind of 30 chest compression, then you deliver 2 breaths by minute 100. Excellent. Compression depth, for how much you're gonna compress, how much of depth? 5 centimeters. Excellent, mashallah. So should we allow the complete recoil between compressions? What does that mean? When you compress on the sternum, on the chest of a patient, and you will do your best to complete the chest recoil. Why is that? Because the coronary perfusion, actually it depends on the filling of the enduring diastole. And we are allowing the blood to fill in the right ventricle to complete the cycle of the heart. So you should, or you have to complete the recoil of the chest between one compression to other. How about the rescue breathing? Is it kind of different if you have a pediatric patient or adult patient? Yeah. For adult patient, we're gonna give 30 chest compression, then 2 breathing, صح? 2 breath. In pediatric, it depends. Are you the first, are you alone, or there is a healthcare provider with you? If you have another healthcare provider with you, so it's gonna be 15 chest compression, then 2 breath, then you're gonna continue 15 chest compression, and then 2 breath. But if you were alone, you're gonna give 30 chest compression, then 2 breath. Assessment of breathing and pulse after the complete of 30 chest compression. After 2 minutes of cycle of CPR. The systematic approach to CPR, early recognition, it's kind of crucial things. Once you recognize unresponsive patient, then you have to call for help and activate the AMS. Just call 911 or assign somebody to call the AMS and assess for circulation. Is there any pulse or no? If there is no pulse, just immediately start the 30 closed chest compression. Use the defibrillator if you have it, the AED device. If it's not available, just wait for the AMS to bring it with them. Then continue high quality CPR and deliver rescue breathing. The AHA chain of survival, early recognition, activation of the AMS, immediate high quality CPR, rapid defibrillation, and basic and advanced emergency medical services. This is kind of the ACLS things, not the BLS. Then advanced life support and post-cardiac arrest care. So what is the most common cause of airway obstruction in unconscious patient? نحن دائما بنسمع انه واحد يقول لك برع لسانه. What does that mean? Yeah, excellent. So the things is, we're gonna see it here. This is the oropharyngeal, this is the anatomy of the nasopharynx and oropharynx. All the things here in this space during the unconsciousness or the patient in the cardiac arrest, all of these muscles are gonna be relaxed, and the oropharyngeal muscles are gonna be obscuring the airway. ما أدري, is my mouse clear? واضح الماوس عندي? Okay, so this area is gonna be obstructed and nothing go there. So the patient is gonna be in airway obstruction. Just in a simple maneuver, we're gonna open it. So how do we open it? In 2 mechanisms. The first one, head tilt chin lift maneuver. It's gonna be by 2 hands. The first one on the forehead of the patient. You're gonna do the neck extension, and the other hand on the jaw and the mandible, and you're gonna pull it out. So the things here, the oropharyngeal airway is gonna be opened all the way and safely to deliver breath to the patient. The second maneuver, jaw thrust maneuver. This is the jaw thrust. And when do we do it? When do we do a jaw thrust maneuver? In trauma. Excellent. Why is that? Because the cervical spine, it's kind of danger if we actually did an hyperextension. So in the trauma patient, the patient usually in a neck collar, or why do we put the patient neck collar? To protect the C-spine. So in jaw thrust, we're gonna do it by 2 hands. One hand, both of them in the lateral of the face, and your finger just below the jaw, and you are trying to push it up, and the mandible to open it there. So this technique is kind of safe in trauma patient and any patient with cervical spine diseases. Okay. How about the obstructed airway? This is Helmick maneuver. Helmick maneuver, this is actually the obstruction of the airway. It's such kind of common in pediatric group because they actually swallow anything in front of them, and it could be risky, and it could go to the airway and obstruct it. So how do we get it out? By doing the Helmick maneuver. The Helmick maneuver, you just make a fist in your right hand or left hand, and the other hand just above it, and you are doing your effort by pushing from downward to upward, from downward to upward, multiple times just below the subxi area. And you, after doing it multiple times, the foreign body is going to be split out. So this is regarding the BLS in basic. And I know most of you, they have a BLS certificate. No need for going in much detail on that. ACLS, this is a big one. So we're gonna talk about the bradycardia in the ACLS, tachycardia, cardiac arrest, and post-cardiac arrest. So let's go in algorithm. So this is the bradycardia. The definition of the bradycardia, when the heart rate is gonna be less than 60, but usually they don't go symptomatically in bradycardia unless the heart rate is less than 50. So first of all, you have a patient coming to you with a heart rate less than 50, just make sure this kind of heart rate 50 per minute causing his instability, or this kind of bradyarrhythmia causing instability to the patient. How can I know that? By looking for specific things. Is your patient hypertensive? Means the blood pressure or systolic blood pressure less than 90, or the MAP less than 65, or is there acutely altered mental status, or is there any signs of shock? Is the patient unconscious? The patient is dizzy, or your patient is severely pale, unresponsive to you? Is there any ischemic chest discomfort? Is your patient in failure or no? If there is no, just monitor and observe why the patient in this kind of heart rate. First of all, just do your things, do your ABC, maintain the airway, assist for breathing, deliver oxygen if your patient is hypoxic, put him on cardiac monitor, see the rhythm, what you are seeing. Let's have an IV access, draw some blood, send for labs, and do a 12-lead ECG if the time is available. If you have a 12-lead ECG or available in front of you and still patient in this instability thinks your patient hypertensive, altered mental status, he's in shock, ischemic heart disease, acute heart failure, yes, just go for atropine, give him 0.5 milligram bolus. If it didn't work, you can repeat another dose. If it didn't work, just go for transcutaneous spacing. Bring the crash cart, put the pads, and put him on transcutaneous spacing, and try to overpace the electricity of the heart. If it didn't work, use medication such as a dopamine, which is beta agonist. And if it didn't work, you can use epinephrine, which is alpha or beta agonist, which is tried to causing tachyarrhythmia because it has an inotropic and chronotropic effect. Then, if all of these things failed and you're still having a bradycardia and your patient is still unstable, just go for transvenous spacing. We're gonna go through a transvenous approach, trying to pace the heart through transvenous approach. Then most of them, they will get it and they will improve after that. This is regarding the bradycardia. Regarding tachycardia with pulse, usually the definition of tachycardia, the heart rate more than 100, but usually they are not symptomatically until the heart rate goes above 150. So once you have a patient with a heart rate above 150, do your best and try to know why your patient in this kind of heart rate. And if you just see it, might be your patient in pain, might be your patient in shock, and he's septic, and we don't know. So just do your clinical workup and your clinical vision. If you try to know why he's tachycardic, treat the cause. Maintain an airway. This is that box actually talking about the ABC. Do your ABC, maintain the airway, deliver oxygen if the patient is desatting. Cardiac monitor to identify the rhythm, see the rhythm, what kind of rhythm we have. Then ask yourself, is this heart rate above the 150 causing a high instability to the patient? What are the instability things? Hypotension, altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. If yes, just go for synchronized cardioversion. Bring the crash cart, put the pads on the patient, synchronizing, and deliver a cardioversion. If no, that يعني لو قلنا مثلا واحد مثلا heart rate حقه 170 180 and he's stable, he's awake, he's not hypotensive, and he's communicating with you, he's not in chest pain, and he's not in failure, ask yourself, is this QRS complex, or is that rhythm or tachycardia, the QRS complex, is it wide or narrow? It's because the treatment is totally different. If it was wide QRS complex, that means this is mostly ventricular tachycardia, and you will give your patient antiarrhythmic medications. We're not gonna talk about the details of what type of medication we're gonna use or how much of doses we're gonna give. Just I am explaining the approach to your such kind of symptoms. If the QRS complex is narrow, how can I know that? I think Dr. Anas Hamam just explained it yesterday for you. How can I differentiate between the QRS complex? Is it wide or narrow? Does anybody know? Excellent. More than 0.12 second or more than 3 small squares, not 2, 3 small squares. If it's more than 3 small squares, that means your QRS complex is wide. But if it was narrow, this is most likely due to an SVT, supraventricular tachycardia. And we have 9 differential diagnoses of SVT. But let's say if it's an SVT, do ECG, 12-lead ECG, try to know what type of rhythm. If it's possible, if it's not, just go for vagal maneuver. We have 4 types of vagal maneuver. We have carotid massage, we have modified, we have Valsalva maneuver, and we have modified Valsalva maneuver. And in pediatric, we have an ice merge. نحط كده ثلج على وجه البيبي. It will stimulate the parareceptor and the vagal nerve, leading to bradycardia. So if adenosine failed, then vagal maneuver failed, we'll go with adenosine. If adenosine didn't work, we'll go with beta blocker and calcium channel blocker. So next, this slide shows the doses of medications and the amount of joule that we use it in SNS. We have a narrow regular, narrow irregular, how much of joule we're gonna use it, if it was wide regular and wide irregular. This is a different talk, and I think it's kind of advanced and beyond your level. Cardiac arrest. So this is the algorithm of cardiac arrest. Once, if you're working in the hospital, once you identified your patient in cardiac arrest, just shout and call for help. Then immediately start for CPR, and somebody is gonna apply the oxygen, and the patient will be attached on the monitor, and they will bring the crash cart. This one is the crash cart. once the crash cart on the pads of the crash cart on the patient, just stop the CPR and check the rhythm. Is your rhythm non-shockable rhythm? This one? Non-shockable rhythm, they are two. Does anybody know what is this rhythm? This one. Asystole, excellent. Mumtaz. This is an asystole, flat line. And this one, there is a QRS, but when you see the patient and when you put your hand on the carotid area, you will feel nothing, no pulse. We call it PEA. PEA means pulseless electrical activity. So once you are checking the rhythm and you see those things, just start the CPR. You will have an IV access, give epinephrine every 3 minutes, and consider advanced airway capnography, meaning that either you go for intubation or you put a supraglottic airway. Then after the 2 minutes, check the rhythm again. If it's still non-shockable rhythm, you will continue this box, epinephrine and ventilation. And try your best and look for reversible causes. Why your patient in cardiac arrest? What are the reversible causes? Here, the reversible causes are, we call it 5 H's and 5 T's. The 5 H's, including hypovolemia, hypoxia, and hydrogen ion, which is acidosis, hypothermia, hyper and hypokalemia. The T's, tension pneumothorax, it will lead to obstructive shock, tamponade, toxins, thrombosis, including pulmonary embolism, and thrombosis, coronary thrombosis, which is mean STEMI or non-STEMI. So we finished with the asystole or non-shockable rhythm, PEA and asystole. Let's go back. Your patient in arrest. Start CPR, connect him to the monitor, check the rhythm. If the rhythm is shockable, yes. What does that mean? VFib or VTAG, ventricular fibrillation or ventricular tachycardia. This is the ventricular tachycardia. You will see very wide, complex, going up and down like this. Ventricular tachycardia. This kind of fibrillatory wave, we call it VFib, ventricular fibrillation. If your patient in that rhythm, just shock him with a 200 joule non-synchronized defibrillation, then immediately continue CPR. Do not check the rhythm, do not check the pulse, just go for CPR after the shock. And better, of course, you're gonna have an IV or IO access. Then after 2 minutes of CPR, check the rhythm again. If the rhythm is still shockable rhythm, continue CPR for 2 minutes and give epinephrine every 3 minutes. And consider advanced airway, either intubation or supraglottic airway. Then after 2 minutes, check the rhythm again. If it's still shockable rhythm, still VTAG or VFib, continue CPR and give amiodarone and look for reversible causes. Why your patient in a shockable rhythm? And these are the reversible causes. So next, طبعا هنا let's assume your patient after the shock and the CPR, or after your CPR got to spontaneous circulation. He came back to life, returned to his spontaneous circulation. Once your patient came back to the spontaneous circulation, we call it ROSC. If the patient achieved ROSC, just go for post-cardiac arrest. This is the post-cardiac arrest algorithm. Your patient achieved ROSC, optimize the ventilation. If the patient not intubated and he's unconscious, just go for securing the airway, tube your patient and deliver oxygen and give him fluid, because one of the complications of chest compression, you're gonna develop cell injury, and the patient will be dehydrated. Give him fluid, give him vasopressor, either epinephrine or norepinephrine, and look for reversible causes why the patient went through cardiac arrest. Most likely those patients who just go for cardiac arrest, especially if they were elderly, the most common cause is myocardial infarction. And then do an ECG. After that, just advance for cardiac catheterization, which is mean PCI. Those patients, most likely, you're gonna find your answer in the PCI, either a complete occlusion of one of the coronary arteries causing ischemia, or there is a specific cause can be corrected, and then you will advance for critical care support, which is beyond your level. يعني. طيب. We finished the second part of our talk today, which is the SLS. Then we'll jump for arrhythmia. I think Dr. Anas yesterday, he talked about the arrhythmia. We're not gonna go in details regarding the arrhythmia and how to detect it and how to read what type of abnormal rhythm. We're gonna just talk about how to approach clinically to the arrhythmia and how to approach a tachycardia or tachyarrhythmia, and what are the instability indicators in the dysrhythmia, and how to manage the atrial fibrillation. So how to approach arrhythmia clinically, it's either your patient is stable or unstable. How can we know that? By the signs of instability. We're going to talk about it just a moment. Is that rhythm, is it tachyrhythm or bradyrhythm? Is the complex narrow or wide? Is it regular or irregular arrhythmia? Causes of bradyarrhythmia: either there is a heart block or there is a toxins causing this kind of bradyarrhythmia, such as, anybody knows which one of the toxins causing bradyarrhythmia? OP, or what do you, organophosphate? Excellent. Beta blocker, calcium channel blocker, digoxin, all of these things causing a bradyarrhythmia. Electrolyte disturbance such as hyperkalemia, ischemia causing a heart blocks. So causes of tachyarrhythmia. The causes of tachyarrhythmia, actually three things: kind of increased atomicity of the sinus node or the ectopic focus, other re-entry or accessory pathway, such this is kind of structural heart diseases, such as the WBW. Ahsant, fantastic, Ray, mashallah. Or triggered rhythm. Instability indicators in cardiac dysarrhythmia. Once you see an arrhythmia, ask yourself, is my patient stable or no? How can I know that? Simply, is your patient hypertensive? Is his systolic blood pressure less than 90? Or is there a systemic hyperperfusion? Is your patient alterly mentated? Or is there any chest pain or dyspnea? And that means your patient in pulmonary edema. Extremely rapid ventricular rate, the heart rate or ventricular response more than 220, which is extremely high in adult. So once you see these, that means your patient is unstable in this kind of rhythm. So how to approach tachycardia in general? Ask yourself immediately, is the QRS complex narrow or wide? If your QRS complex is narrow, which means less than 3 small squares, is it regular rhythm or irregular rhythm? If it was irregular, you're gonna be lucky because you have only three things causing the irregularity in tachyarrhythmia. narrow complex tachyarrhythmia, they are atrial fibrillation and something we call it MAT, multifocal atrial tachycardia. I have no idea if Dr. Anas talked about it or not. Atrial flutter with variable block. If your QRS complex is narrow and regular, either is going to be one of 6: sinus tachycardia, atrial tachycardia, atrioventricular re-entry tachycardia, atrioventricular nodal re-entry tachycardia, junctional tachycardia, atrial flutter. طبعا هذا البوكس يعني هنا من هنا لتحت هذا كله in the medical school they used to teach us, and this is SVT, supraventricular tachycardia. And management is kind of different from this one and this one. But if your QRS complex is wide, more than 3 small squares, ask yourself, is it regular or regular? If it was regular, wide complex tachycardia, if you are in doubt, just call it a ventricular tachycardia. It is ventricular tachycardia until proven otherwise. إلا إذا كنت أنت expert مرة وتعرف تقرأ ECG كويس, you can differentiate between something called SVT plus bundle branch block, which is beyond your level, very advanced. طيب إذا كان wide QRS complex and irregular, either it could be polymorphic VTAC, polymorphic ventricular tachycardia, or any kind of this irregular narrow complex اللي هم atrial fibrillation أو MAT أو atrial flutter بس معاهم bundle branch block, لأن البندل branch block فتح الكومبلكس. راشد excellent. طيب next. لا ما شاء الله في معلومات كويسة يعني. أنا كان نفسي إنه we have time حتى نشرح بالضبط إيش الفرق بين الاثنين. طيب we have a stable narrow complex tachycardia. If you have a stable narrow complex tachycardia, ask yourself, is it regular or irregular rhythm? If it was irregular, either atrial fibrillation أو MAT أو atrial flutter with variable block. Atrial fibrillation, we're going to talk in detail how do we treat it. So this kind of approach for treatment of stable narrow complex tachycardia. If it was regular rhythm, attempt the vagal maneuver. We've just talked it in the ACS. If the vagal maneuver failed, go for adenosine, 6 milligram. Then if failed, just double the dose, 12 milligram IV push. If converted, alhamdulillah. If not converted, يعني ما رجع sinus rhythm, ممكن we can go for rate control by beta blocker or calcium channel blocker. طيب, if you have a stable patient, يعني ما في signs of instability, stable patient with wide complex tachycardia. طبعا إذا كان unstable, immediately we'll go for synchronized cardioversion. But if your patient is a stable wide complex tachycardia, ask yourself, is it regular or irregular? If it's regular, this is VTAC until proven otherwise. So you're gonna use antiarrhythmic medications such as procainamide or amiodarone. But if it was irregular, either it could be polymorphic VTAC, as you can see in my mouse. Polymorphic VTAC يعني VTAC بس ايش؟ polymorphic. أو something called torsade de poids. أو atrial fibrillation بس معاها WBW. أو bundle branch block. طيب يعني you can ignore this green box, just concentrate on this one. Regular wide complex tachycardia, it's a VTAG until proven otherwise, and you will use procainamide or amiodarone, which is antiarrhythmic medication. But if it was wide complex or irregular, this is kind of advanced things. So hard to explain it in just a brief time. طيب, this is the approach of atrial flutter. Atrial fibrillation. Atrial fibrillation with rapid ventricular response. As usual, is your patient stable or not? If he is unstable, immediately for cardioversion. But if he was stable, conscious, alert, talking to you, not in chest pain, not in his OB, and he's obeying command, that means your patient is stable. Ask yourself, is your patient candidate for cardioversion? That means atrial fibrillation with a rapid ventricular response, the heart rate above 150, and the patient is stable. Is my patient candidate for cardioversion? Why do we cardiovert them? We want to regain the normal sinus rhythm. Who's candidate for the cardioversion? If the symptoms of atrial fibrillation is less than 40 hours, or there is no left ventricular dysfunction, or your patient has no valvular diseases, and there is no history of thromboembolism, such as stroke or DVT, therapeutic, and your patient on therapeutic anticoagulants, this is candidate for cardioversion. Follow the blue things: sedation and synchronized cardioversion. Then give oral anticoagulant. Then your patient will be retained and regain the sinus rhythm. If your patient not candidate for cardioversion, we will go with something called rate control. زي ما قال فارس. مرحبا فارس. So we're gonna go with the rate control. Our goal, the heart rate will be less than 100. The management we can use, such as a medication, calcium channel blocker, the most common one, diltiazem, and beta blocker, but we should avoid it in asthmatic and COPD, and digoxin and amiodarone. One of those you can choose, depends on your clinical status regarding the condition of your patient and which one is better than the other. After that, all of your patients of atrial fibrillation, most of them, 90%, they need an oral anticoagulants after the rate control or rhythm control. Okay, who knows the two ECG features of atrial fibrillation? This is the normal sinus rhythm, and this is the AFib. There are two ECG features. If you just saw them, this is an atrial fibrillation. One, absent P wave, excellent. The next, irregular, fantastic. So it's either, it should be absence of P wave and irregular. What we can see, these are fibrillatory wave, but there is no clear P wave such as in the normal sinus rhythm. These are very beautiful and very obvious P wave, but in the atrial fibrillation, we don't see it. And the rhythm, it should be irregular and regular. We can see a single beat here and 3 beats together, then 2 beats, 3 beats, 2 beats, 1 beat, kind of irregular and irregular. This is the last guideline regarding the treatment of atrial fibrillation. This group who are candidate for cardioversion, and the other group who they are not candidate for cardioversion, they are candidate for rate control, and this one for rhythm control. Ask yourself, is my patient unstable due to the atrial fibrillation? Or the atrial fibrillation, it's non-valvular atrial fibrillation. There is no valvular diseases, and the symptoms less than 12 hours and no recent stroke. Or non-valvular atrial fibrillation and the symptoms less than 48 hours, and there is something called CHATS-2 score. CHATS-2, it actually score assessing the risk of thromboembolic events. If your patient has a low score, that means your patient is candidate for cardioversion. You were gonna give him oral anticoagulant, then for cardioversion immediately without any medications. And it's kind of very safe. But if your patient has a valvular atrial fibrillation, or the symptoms, the patient has a recent stroke, or your patient has a CHAT score 2 or more, or the symptoms more than 48 hours, that means your patient is not candidate for cardioversion. Your patient is candidate for rate control, and you're gonna control the rate by medications, either beta blocker, calcium channel blocker, digoxin, or amiodarone. Then give your patient an oral anticoagulant for 3 weeks. After 3 weeks, your patient is gonna come to the hospital for cardioversion. After the cardioversion, he should continue for oral anticoagulants. This is the CHATS-2 score. If there is evidence of congestive heart failure, if there is an evidence of hypertension, or your patient is above 65, or your patient is diabetic, or there is a history of stroke or TIA recently, you will calculate it and see how much your patient is at risk of thromboembolic events. So we finished the arrhythmia. ناخد بريك مدة كده 5 دقائق 3 دقائق ونرجع لكم. الساعة كم دحين؟ 8:05 إن شاء الله نرجع. طيب ناخد بريك كده 5 دقائق ونكمل. مرحبا جميعا. نرجع نكمل. كل موجود. يلا بسم الله. طيب نكمل. ACS Acute Coronary Syndrome. طبعا I think most of us they know what is the ACS and they know in details the pathophysiology and how do they present, and one of the most common subject in medicine. We're gonna talk how to diagnose the ACS, general treatment of ACS. We're not gonna go in much detail, just go through cases. The ACS actually, it's kind of three diseases or three types, either STEMI, ST elevation myocardial infarction, or non-ST elevation myocardial infarction, or unstable angina. In STEMI, there is a complete occlusion of the coronary artery leading to the full thickness of myocardial death. In non-STEMI, there is a subendocardial ischemia. So the pathophysiology is kind of different. In unstable angina, there is a critical occlusion of the coronary artery leading to demand ischemia. When the patient in distress, they will develop an ischemia. So it's not a complete occlusion, but there is a risk of developing STEMI. Let's go through cases. Be ready. Yalla. 60 years old male patient with typical retrosternal chest pain for 1 hour. Vital signs kind of accepted. Troponin is normal. ECG is this. What do you think? Yeah, STEMI. This is inferior STEMI. طيب واحد يجي يسألني يقول لي MI كلمة عامة أو نحن نقول what type of MI. عندنا هنا ST elevation myocardial infarction. طب واحد يجي يسألني يقول لي why the troponin is normal. غريب صح؟ طيب the issue is the troponin it doesn't rise until the patient is developing a myocardial or complete occlusion of the coronary after 3 hours. بعد ما تبدأ symptoms, بعد ما يكون ال ST elevation or the patient is developing an ST elevation after 3 hours, it takes time to rise. So it's not a must to have a high troponin in STEMI. Next case. 55 years old female patient with a chest tightness and vomiting for 6 hours. Vital signs kind of normal. Troponin is high. And ECG is this. Yeah, CKMB is the first, but the high sensitive troponin, which is more sensitive and specific. أحسنتم. Non-STEMI, excellent. So this is non-STEMI. How can we know that? The non-STEMI, either it presents with ST depression here and there, here and there, and here and there. ST depression, we can see it here. ST depression, ST depression, ST depression, ST depression, ST depression. The non-STEMI, it could be present with normal ECG or signs of ischemia, which is ST depression or T-wave inversion, with high cardiac enzymes. So this is the difference between STEMI and versus non-STEMI. Case 3, 60 years old male patient with new onset typical exertional retrosternal chest pain for 2 days and relieved with nitrate and rest, lasting for 20 minutes. The ECG shows this, and troponin is normal. What do you think is the diagnosis? يا سلام. جميل جميل جدا. يا سلام. Unstable angina. So unstable angina, the patient, there is a specific definition, 3 types of definition, or 3 definitions for unstable angina. One of them, the new onset typical chest pain, and the troponin, it could be normal, and the ECG, such a beautiful like this. There is no signs of ischemia, normal sinus rhythm, no any ST segment abnormality, very beautiful ECG. But the patient has a specific and very concerning history of cardiac ischemic chest pain. So those patients need to be admitted with serial ECG and serial cardiac marker, plus they need an echo and interventional diagnostic PCI. They will go and explore the coronary and see if there is any lesion or any occlusion or possibility of narrowing of the coronary arteries. Treatment, the general treatment of ACS, there is a beautiful mnemonic called MONA B, morphine. What type of painkiller? Any type of painkiller you want to use it. We use a morphine, one of the commonest painkiller in the emergency. Deliver oxygen if your patient is hypoxic, and give him nitrate for pain control and for relieving the, it will lead to coronary dilatation, and give him antiplatelets medication such as an aspirin, and you can add other antiplatelet medications such as clopidogrel or ticagrelol, and beta blocker. Those are the general medications we use it in the ACS. In STEMI plus the MONAB, we're gonna the patient, they need a PCI, percutaneous coronary intervention, or thrombolytic therapy. If you are working in a place they don't have a cardiac center and they don't have a PCI, just go for thrombolytic therapy. Next, we're gonna talk about hypertensive emergency. Our objectives, we're gonna talk about definitions, some types of hypertensive emergency and their treatment. The definition of hypertensive emergency is a hypertensive crisis when the systolic blood pressure raising above 180 and the diastolic blood pressure raising above 120 with end organ damage. What are the organs that could be damaged? Either brain, heart, aorta, kidneys, or eyes. Hypertensive urgency, it will be a marked elevation in the blood pressure. It could be above 180 and diastolic above 120, but there is no organ damage. We've seen a lot of people, they come to the hospital with the high reading of blood pressure, 200, 210, but there is no evidence of end organ damage. We call them, it's kind of situation in hypertensive urgency. طيب. Next, يلا, let's see. How many of hypertensive emergencies do you know? أو خلينا نقول, what do you think? How many of hypertensive emergencies are there? 3, 4, 2, 4, يلا, 3. طيب. They are 13. 13 things that could be damaged with a high blood pressure. And you have to look for 13 things when your patient coming into the emergency with the high reading of blood pressure. Yalla, let's go through cases. 55 years old male patient with left-sided weakness for 2 hours. The initial vitals showing blood pressure 210 over 110. CT brain shows this. What is the diagnosis? ايش مو واضح معلش. stroke. ايوه بس what type of stroke? Yeah, it is hypertensive emergency. بس hemorrhagic stroke. Excellent. So this ICH, we call it intracranial hemorrhage. We see it, this is in the right side, the hyperdense white color in the right side showing hyperdense area, which indicates blood. So there is intracranial hemorrhage with shifting, with midline shift, causing his symptoms of this patient. Like 50 years old male patient with chest pain for 3 hours. Initial blood pressure 190/100. ECG is non-specific. Diagnosis with X-ray. Yeah. LVH للأسف. Dissection. Aortic dissection, wide mediastinum, pulmonary edema, pulmonary hypertension, heart failure, aortic dissection, left side heart failure, pericardial effusion, hemothorax dissection, LVH. يعني 40% جابوها صح. Excellent. This is dissection. طيب, what do we see here in this X-ray? Very obvious wide mediastinum. How do we calculate the mediastinum? We just go for the middle in the hilum and we calculate this diameter. And very obvious there is a wide mediastinum. This is the first part. The second part, the mediastinum, it should run with the pericardial margin. هنا مفروض هذا اللي هنا مفروض يمشي كذا pericardial margin. ولكن we can see there is a very wide mediastinum هنا يعني خارج على برا with whitish color in this space which indicates blood. So this is an aortic dissection and this patient needs to go for CT imaging, CT angio to see what type of dissection he has. So this is aortic dissection. 45 years old female patient with SOB, shortness of breath for 2 days. Blood pressure 195/110, respiratory rate which is high 29, and oxygen saturation is 85. She is desatting and she is in respiratory distress. X-ray is this. PE pulmonary edema. يلا ABO ماني عارف ايش قصده ABO. يلا PE pulmonary edema, PE RDS respiratory distress syndrome, pulmonary edema, pulmonary embolism, PE edema. طيب pulmonary hypertension. طيب this is pulmonary edema. We can see the X-ray. It's very clear congested lung, bilateral with bilateral pleural effusion. We don't see the costophrenic angle on the right side, even in the left side. So that's mean there is something obscuring that phrenic angle, which is fluid. And this patient with this kind of history, we are seeing this is a pleural effusion, bilateral. Plus, there is very clear cephalization, which means there is a very obvious congested lung. اللنج المفروض تكون يعني زي كده black in both sides. But what we can see here, a very wide and congested lung. So that means this patient in pulmonary edema. 60 years old male patient with active chest pain, blood pressure 185/100, ECG showing this. Diagnosis. عمري قال STEMI، واحد myocardial infarction، LVH acute myocardial infarction، STEMI and STEMI. يلا طيب اللي يقول STEMI, do you know what type of STEMI? Is it anterior, inferior? Is it lateral? Is it posterior? Anterior. Excellent. This is anterior STEMI. Anterior STEMI, we can see the clear ST elevation in the anterior leads V1, V2, V3, and V4. Very clear ST elevation, myocardial infarction. The only things, the only things we can the only single test we can use it to diagnose STEMI is the ECG. This schedule showing the other differential of hypertensive emergency, we can see the aortic dissection, acute hypertensive pulmonary edema, acute myocardial infarction, sympathetic crisis, which means if the patient on drug addict on cocaine or amphetamine, اللي هم عندنا الكوكايين اللي هو كبتاجون مشهور عندنا, acute renal failure, and eclampsia, preeclampsia, hypertensive encephalopathy, subarachnoid hemorrhage, and intracerebral hemorrhage, and acute ischemic stroke. طبعا هذا الجدول بيبين لنا the therapeutic goal of each specific disease and the agent we can use it, plus the risk factor of specific medication and specific comments regarding the management of each type. If you have time, just go and read them. طيب, lastly, we're going to talk about cardiac tamponade. طيب, objectives. عندنا بس recognition and treatment of pericardial tamponade. This is the last part we're going to talk about. Definition of cardiac tamponade. طيب, قبل لا أوريكم الديفينيشن بوريكم حاجة. طيب, what do we see here? This is an echo showing the chambers of the heart, and this kind of black color in this space, it is a pericardial effusion. And even here, this one is the pericardial effusion. Normally, it should be nothing in that space. But if there is an accumulation of the fluid in this space leading to pericardial effusion, and then if it's gonna increase and causing an obstructive pattern on the right ventricle, it will cause tamponade. So let's go back to the definition of the tamponade. It is restriction of the ventricular filling during diastole due to accumulation of the fluid within pericardial sac. So it's kind of clinical diagnosis plus an echo diagnosis. We don't know if that fluid causing a restriction to the ventricle unless we see it by our eyes by echo. Causes either medical or traumatic. The traumatic cause of pericardial or cardiac tamponade, if it's traumatic, blood is the cause usually in the penetrating injury or blunt trauma. If there is an accumulation in the pericardial space, if you have traumatic patient coming to you and you put your probe over the chest and you see an effusion around the heart, so this is blood unproven otherwise. Medical causes such as oncology patients, they have metastasis anywhere. It could be an invasion through the pericardial by the metastatic cells leading to pericardial effusion. If your patient in end-stage renal disease and he is on dialysis and the patient is overloaded and didn't go for his session for dialysis, he might have a pericardial or cardiac tamponade. Next, clinical features. The most common complaint for pericardial cardiac tamponade is the shortness of breath. Then the low blood pressure with the respiratory distress and chest pain. There is something called زي ما قال راكان a big striate, which is the 3 Ds. Distension of the jugular vein, distant heart sound, plus decrease of the blood pressure. So these are the three diagnostic or three things that associated with the cardiac tamponade. Does anybody knows what does this ECG show? Low voltage يعني غير low voltage مو مرة low voltage مين هذا؟ سهيلة وعد مين كمان؟ يلا راكان ممتازين S1 Q3 T3 ما هي كاملة Q3 ما في T3 Q3 T3 تكون في lead 3 وليد 3 هنا ما هو فيه. طيب excellent. This is electrical alternance. What does that mean? This is an apical view showing a significant pericardial effusion and the heart is swinging back and forth. شوفوا بيرقص بيتمايل يمين يسار. What does that mean? In the ECG, we put our leads on the patient and we are capturing the beats from the heart. And once the heart is close to the leads, we're gonna see this beat. But if the heart is going away from the leads, we're gonna see this beat. As you've said, low voltage, or positive deflection and negative deflection, or big square QRS complex, or small QRS complex. So this is up and down, up and down, up and down, up and down. This is something called electrical alternance. So as I've said, this is an echo view of the heart showing. This is parasternal view showing the right ventricle, right atrium, left ventricle, left atrium, sorry, I think this is transesophageal echo. والله العالم. طيب. The pericardial tamponade. Does anybody know what is the abnormality in this echo? غير البريكارديال fusion. VSD لا ما VSD. Hypokinetic لا hyperkinetic. This is hyperkinetic vegetation mitral collapse RV. أحسنت. مين قال collapse RV؟ collapse RV. Rakan. Excellent, Rakan. So this is collapsed RV. What do we see here? This is the RV. This is the septum, interventricular septum. This is the LV. This is the aortic root. This is the mitral valve. And this is the left atrium. And that is the pericardium. And it's filled with fluid. So there is a pericardial effusion causing tamponade. كيف عرفت انها causing tamponade؟ tamponade نرجع للتعريف مرة ثانية. Restriction of the ventricular filling يعني during diastole. During diastole due to an accumulation of the fluid within the precardial sac. What do we see here? During diastole, the ventricle should be completely relaxed. يعني بتاخذ راحتها في relaxation, which it doesn't shows here in the right ventricle. During أنا يا ريت أقدر أوقف الفيديو بس ماني قادر. During diastole, there is an inward of the ventricular wall of the right ventricle toward the ventricle. Normally it should be to the outward يعني زي كذا. يعني الفنتريكل الرايت ventricle المفروض يكون كذا smoothly and bulging to the outside or to the outward during diastole, which it doesn't here. It going inward during diastole. So that means the RV is collapsing during diastole, and that is the diagnostic things of tamponade. Management, ABC, then give fluid to the patient and do emergency pericardiocentesis, taking out the accumulated blood from the pericardial sac, and you're gonna see dramatic improvement in the vital and the clinical situation of your patient. Lastly, I would thank you all of you, and أي سؤال مرحبا بكم. شكرا جزيلا.
يعطيك العافية دكتور عبد الرحمن. طيب حنبدأ ناخذ الأسئلة، بس حنسوي شير سكرين للأسئلة لو ممكن. حميدة.
ايوه اهلا، ثواني بس وفرقة.
طيب بس أنا عندي بعد إذنكم كده أستأذنكم، عندنا مقطعين فيديو كده قصار نشوفهم سوا.
طيب أوكي.
طيب واضح اليوتيوب معايا؟
أيوة تمام.
طيب هنا بس بوريكم كيف this is a real case of cardiac arrest and how do we doing a defibrillation to the patient. They are checking the rhythm and they deliver the shock to the patient. After that, they should continue the CPR immediately for 2 minutes. Then they're gonna check the rhythm again. And if it was shockable, they're gonna shock the patient. The other video, this is for synchronized cardio. واضح معايا كده الفيديو؟
أيوة تمام.
طيب this is regarding the synchronized cardioversion. This is the propofol or etomidate, which is the sedation. We have to sedate the patient. This patient is kind of stable or unstable tachycardia or tachyarrhythmia, and they're gonna deliver a synchronized cardioversion for them, for her. They're gonna sedate the patient because it's kind of very painful procedure. بعد the sedation, we can see here the heart rate, it's 170. The blood pressure is fantastic, but it could be any other thing of instability to the patient. We don't know why the cardioverter. Now the patient is in deep sedation and there is no response. Here the heart rate is showing 167, and these dots above the QRS complex, meaning the crash card has been sitting for the synchronized cardioversion, and we can see the cardioversion here. The shock delivered to the patient, and immediately there is improving in the heart rate, going back to the sinus rhythm. Very safe procedure. It actually it's a class 1A indication in the AHA for treating the arrhythmia, which is superior for above the medications. So we can see here the heart rate just went down from 170 to 100 again. خلاص كده نقدر نبين الأسئلة.
طيب دكتور، هذا أول سؤال حنبدأ فيه، أو بعدها في أسئلة ما هي موجودة هنا أنا حقولها من الشات.
طيب مو مشكلة.
طيب if the patient bradycardia, should we start IV fluid first or we should give the atropine first?
طبعا I think there is no relation between those things. في البداية أول حاجة do your ABC. and put the patient on the monitor. And if your patient showing a bradycardia and لو كان البيشنت is in fluid deficit, that means البيشنت it should be in tachycardia ما هو bradycardia, except in specific situation. So is your patient stable or not? If he is stable, look for other causes and treat it. ممكن واحدة منها severe dehydration أو severe intraperitoneal bleeding leading to bradycardia ممكن. So fluid it could help. ولكن if your patient is unstable, just don't wait or don't take so much time until the fluid is being finished. Go for atropine and the algorithm of bradycardia.
Okay. السؤال الثاني, does the ICE work with adults?
No, it doesn't. It works with the pediatric.
Okay, تمام. If patient came with tachycardia and chest pain, so it's suspected MI, why are we gonna start a cardioversion rather than antiplatelet?
So if the patient coming in with tachyarrhythmia and there is an ischemic chest pain, that condition, it could put the patient in something we call it demand ischemia. That demand ischemia due to the rapid ventricular response. If we slowed the heart rate down, the chest pain could resolve. So we have very clear cause leading to that chest pain. Why don't we stop it? If we stop it, alhamdulillah, and the chest pain خلاص راح, now we've knew the cause. If the patient has a risk of myocardial infarction, of course, we're gonna give him antiplatelets and the full medication that he needs. But if he was in tachyarrhythmia, we should correct the tachyarrhythmia first. واضح؟
Okay, تمام. طيب, how I can treat acidosis and hypo and hyperkalemia?
I think this question is being meant in cardiac arrest. If your patient known to have an hyperkalemia, how can I know? You can simply draw VBG and you can see the potassium level in the VBG. There is a specific approach and treatment for hyperkalemia in cardiac arrest. Either you can use insulin with dextrose or sodium bicarb plus calcium gluconate or calcium chloride in cardiac arrest. The acidosis can be corrected with sodium bicarb during cardiac arrest.
Okay, next, what's better in management of the atrial fibrillation rate control, beta blocker or calcium channel blocker? And on what?
The first part, which one is better? It depends on your clinical scenario and depends on your patient. Which one is better regarding the clinical status of the patient? If the patient was asthmatic or in hyperactive airway disease, please avoid the beta blocker, especially non-selective. But if it was selective beta blocker, nice to use it. But the most common medication used in atrial fibrillation is diltiazem. Regarding the controlling the heart rate, it's a calcium channel blocker, the medication called diltiazem. But there is a significant side effect of diltiazem, which can cause a significant hypotension on the patient. Second part, and on what basis can we choose between them? طبعا اتوقع اني جاوبت السؤال ان الكالسيوم channel blocker is the preferable agent over the beta blocker unless there is a specific condition we can go through it.
Okay, if CHAD score is high, can we give the patient fibrinolytic?
طبعا هنا في misunderstanding. I think fibrinolytics, it's kind of medication that light the thrombosis. We give in atrial fibrillation oral anticoagulants. We don't give fibrinolytics at all. So if the CHAD score is high, we're gonna give oral anticoagulants. But if the CHAD score is low, we might not giving oral anticoagulant. It depends from patient to other.
How can we assess for valvular disease in the emergency department?
ايوه كمل.
Okay, if atrial fibrillation patient is unstable and we need to cardiovert immediately.
طيب, very nice question. Alhamdulillah, I'm working in National Guard Hospital. Every single patient, most of our patient, we know their background. يكون البيشنت عندنا, we know the background of the patient, and we know the patient, most of them, they have echo, and we know how to deal with them. If you're working in the place that provides such an information, fantastic. Don't jump for that. But you've said if your patient is unstable, I don't care if he has a valvular disease or not. If I didn't convert that rhythm immediately, my patient is gonna die. So I don't care if he has a valvular issue or no. Any unstable patient, immediately go for cardioversion. But if you have a stable patient and he has valvular disease, please do not try to cardiovert them. Go for rhythm, go for rate control.
Okay. When to consider a peaking anti-wave, more than 10 or more than 5?
I think Dr. Anas talked about it last lecture. The T wave, it has multiple forms. And how does it present in the ECG? One of those things, the hyperacute or peak T wave. And the peak T wave, it could show a sign of ischemia or signs of hyperkalemia. And every one of those, it's kind of different in definition. But it should be at least more than 25 of the QRS complex.
Okay, why it's unstable? It's not developed progressively. I don't know.
يمكن قصدهم why unstable patient we go for immediate cardioversion. If we didn't correct the abnormal rhythm immediately, this instability, which is low blood pressure, or the patient is unconscious, or decreased level of consciousness, there is ischemic chest pain, or the patient is in failure, might deteriorate fastly and the patient will arrest. So we have to correct the abnormal rhythm immediately before going for the cardiac arrest, and we might lose the patient.
It could be related للسؤال حق unstable angina.
Why is unstable angina isn't developed progressively?
Could be related أنا ماني عارفة مثال السؤال.
Could be unstable angina. It's a risky things. They might develop or progress to STEMI, complete occlusion. So those patients need to be those patients need to be admitted for further management and further workup. They need a PCI to be done, diagnostic PCI, to see if there is any critical occlusion, and they might need a stent to be put in there. Primary treatment, what is the primary treatment of hypertension? I think this kind of answer, it's beyond the emergency. This is not the scope of the emergency, it's scope of family medicine and internal medicine. We have two types, primary and secondary hypertension. We have multiple medication we can be used. It depends on the guidelines and depends on the specific type of patients, but common medication can be used: calcium channel blocker, beta blocker, and ACE inhibitor, those, and hydralazine and diuretics. Those medication are common medication, common group of family using in hypertension.
Okay. دكتور في أسئلة بس إنها ما هي في البرزنتيشن. What's the role of streptokinase in mitral myocardial infarction?
It has a major role. Streptokinase is one of the medication that categorized under the thrombolytics. Thrombolytics, there are multiple medication. One of them, streptokinase. The thrombolytics, it is a must if there is no non-PCI center. If you have a patient with a STEMI, ST elevation myocardial infarction, and you are working in a place there is non-PCI center, you don't have a cardiologist or interventional cardiologist in the world who is doing the intervention for taking the thrombus out, or the next hospital has a PCI center is far away from you, you have to use the thrombolytic, because you're gonna save a life with this kind of medication, but it has some complication.
Okay, next question. What's the drug of choice of the hypertension patient in the emergency department in the renal failure?
In renal failure, if you have a patient in renal, if you have a patient in the renal failure, how can we pick that up? It depends on the clinical presentation of the patient. Usually those patients, they are, there is non-specific complaint, but the drug of choice in acute renal failure, a medication called phenolodobam. Phenolodobam, it's kind of an IV medication that we use, but it's not available in all hospitals. There is other medication can be used, nicardipine, one of them. Nicardipine can be used in such a case, which is calcium channel blocker.
Next, can we use ICE with wide tachycardia in adults?
Can we use إيش معلش?
Can we use ICE with wide tachycardia in adults?
لا, ICE, it's one of the vagal maneuver that actually stimulates the vagus nerve, but it doesn't work in adult. But if you have a pediatric patient with wide complex tachycardia, even though the vagal maneuver doesn't work, even the ICE, it doesn't work. The wide complex, it has a different approach, as we said, stable or unstable. Stable, you will think about antiarrhythmic medication. The vagal maneuver, it doesn't work with the wide complex tachyarrhythmia.
Okay. Next, which cardiac medication to be given slowly or push? Could you mention, please?
Most of our medication, we give it slowly, except in some condition. Adenosine, which is the preferable drug in narrow complex tachycardia, we give it a push and very fast with a flush after it immediately. But the other medication, usually we give it slowly.
Okay. Next, when to use warfarin and atrial fibrillation in case of patient hypertension and diabetes?
Warfarin, it's an oral anticoagulant that can be used for a patient with a high CHAT score. If we have a patient with a high CHAT score, the preferable agent is apixaban, which is the new oral anticoagulant. But in some condition, the apixaban, it's contraindicated in some situation. So we go with warfarin. Warfarin, it can be used, but it needs to be monitored closely because it has a very side effect, which is bleeding. But before going with the warfarin, we have to give heparin first. After the heparin, we can give the warfarin as a bridging, because the warfarin, it doesn't work immediately. It takes 3 times until it works. So before that time, we will admit the patient and we'll give him IV heparin. After the 3rd day of heparin, the warfarin is gonna be functioning in the body.
Okay. If you have patients with the ventricular tachycardia with pulse and unstable and give first shock with the 100, still not converted, I will give again 100, or I will increase policies.
Yeah, joule. We will increase the joule. Once you have a patient with the VTAC, ventricular tachycardia, and he's unstable, start with a 100 joule of synchronized cardioversion. If it didn't succeed and return to sinus rhythm, you can increase the joule. You can go up to 360.
Okay. Why in post-cardiac arrest, they reduce the patient temperature? They use ice pack for them. Why?
This is one of the neuroprotective measures called hypothermia. We will induce hypothermia in post-cardiac arrest. Every patient who has been through cardiac arrest, all of his cells in the body is going to be injured. And one of the most critical and crucial cells we care about in cardiac arrest is the brain tissue. So the brain tissue will be, during the cardiac arrest, will be hypoxic and it will be damaged. And in the brain edema, one of the protective measures and showing a good evidence regarding protection of the neural cell during cardiac or post-cardiac arrest is the hypothermia. We will induce a hypothermia going down to 32, around 33. We'll apply ice on the patient and we will try our best to cool him as much as we can.
Okay. In case of renal failure, which kind of anticoagulant can we use?
Warfarin is a good choice.
Okay. If I have patients with heart failure secondary to acute coronary syndrome or with acute kidney injury, can I use loop diuretics?
With acute kidney injury and heart failure?
Yes.
I think this question means if your patient in hypertensive emergency and has multiple issues or dual systematic involvement, pulmonary edema and acute kidney injury. In this kind of situation, very fantastic medication called IV nitroglycerin, which is the drug of choice in pulmonary edema. Even it will improve the kidney perfusion, so it's a nice medication. The diuretics is gonna worsen the kidney function test more and more.
Okay. How to treat a chest pain for a patient with tachycardia?
If we're talking about the tachyarrhythmia and patient reaching above 150 and he has an active chest pain, ask yourself, this patient is stable or not? With this kind of ischemic chest pain means unstable, so you're gonna immediately synchronize cardioversion for that patient.
Okay, if patient can produce urine, diuretics. If no, urination in IV.
If patient can produce urine, diuretics. If no urination in IV. ماني فاهم صراحة. ما أدري إذا كان واضح ولا لا.
هو سؤال في الشات. To decrease the coagulopathy, the use of hypothermia. If patient can produce.
Hypothermia, actually, it induced the coagulopathy and induced DIC. So one of the complications of hypothermia is the DIC. Actually, it's been a very big talk regarding the hypothermia, but the last test evidence showing do your best trying to prevent hyperthermia. This is regarding the last evidence showing up last year. Do your best trying to avoid hyperthermia, but some evidence suggesting hypothermia, it's neuroprotective measures. We can use it post-cardiac arrest.
Okay. In case of patient hypertension stable on statin and thiazide, no edema, what can we add to him?
معلش مرة ثانية.
In case of patient heart failure stable on statin and thiazide, no edema, what can we do or what can we add to him?
Edema, it's not the part of things that actually push us for treatment in heart failure. The symptoms wise, the generalized anasarca, and the most important thing, which is the lung congestion. If the patient is kind of stable in his medication, so he should continue in his medication. But if he is developing a deterioration and he is worsening in his condition, there are multiple things we can use. If he's in respiratory distress, we can apply a BiPAP for him. But if he's not in respiratory distress, we can increase the dose of furosemide or diuretics for a specific time of period, and we can get it back in his basic dose.
Okay, the last one, in case of patient MI, after 2 hours, he developed low blood pressure. What's the management?
So that's mean the patient went through cardiogenic shock. If you have a patient with myocardial infarction and he has a low blood pressure, this is mostly due to a cardiogenic shock. There is a specific approach and specific treatment regarding those kind of patients. The diagnostic the most curative thing and the most saving things for those patients, they have to go for PCI immediately. They need to go for PCI for taking this thrombus out, because the heart went through severely hyperperfusion and the coronary artery, they are occluded. So safely, and the best thing for the patient, they have to go for PCI, plus they have to go anti-ischemic measures, which is aspirin, a painkiller, nitrate. But nitrate in this kind of situation is contraindicated because the patient is hypertensive. One of the complications of nitrate causing hypertension. So we're going to avoid it. Plus, if the patient is still not improving and he's deteriorating his vitals, we can give him a vasopressors and inotropic medications, such as epinephrine and norepinephrine.
يعطيك العافية.
الله يعافيك.
كانت محاضرة جدا مفيدة وممتعة. نشكر جميع حضوره، وأتمنى أنكم تكونوا استفدتوا واستمتعتوا. وإن شاء الله نشوفكم في لقائنا القادم بكرة. نشوفكم على خير إن شاء الله. شكرا دكتور عبد الرحمن على وقتك وجهدك.
شكرا جزيلا.